Hi, everyone. Hello, and welcome to People for PrEP, Identifying Barriers to HIV Prevention. I'm your moderator, Rachel Deer with DKB Med. Thank you so much for joining us this evening. All right, we've got a packed house and people are still coming in, so this is really great to see. So we've got some important topics to talk about with you this evening. I just want to say that we're really excited to bring this very important webinar today to all of you on the topic of PrEP. We've got both clinicians and community members. And before I introduce them, I do have a few housekeeping items. The first is please mute yourself so that we can give our presenters our undivided attention. You're able to submit questions in the chat. Questions will be addressed during our Q&A session at the end of the presentation. At the conclusion, you'll be able to access the evaluation to claim your CME and CE credit if that's what you'd like to do. A link will appear in the chat and you'll receive an email after as well. Your thoughts and comments are very important and they help us develop activities on this and similar topics in the future. You'll also be emailed a copy of the slides. And for any technical difficulties or related questions, you can direct them to my colleague, Faith. Faith is one of the folks with the same virtual background, so it's easy to spot her. And my colleague, Matt, is monitoring our Facebook feeds, so hello to all of our Facebook friends. So let's get back to our slides. Okay, and at this time, I'd like to ask all of our wonderful faculty to turn their cameras on and they can unmute themselves. So we will start with Quentin. And you might be muted.
There, I was getting a notification that said I wasn't allowed to unmute myself. Good evening, everyone. I'm Dr. Quentin Robinson. I'm an infectious diseases physician in Atlanta, Georgia.
Thanks, Quentin. And Dr. Beringer.
Oh, I was getting the same message that I couldn't unmute myself, but here we are. Hello, everyone. My name is Augustina Beringer. I am a PA and have a doctorate in global health and disaster medicine. I'm the Chief Medical Officer for Heart to Heart International, a healthcare NGO based out of Kansas City, Missouri.
Thanks. And Melinda?
Hi, my name is Melinda Pippick. I'm a nurse practitioner. I currently practice in primary care at a federally qualified health center in the south side of Chicago called TCA Health. In my past role for about 5 years, I worked in retail health and sat on the corporate-wide sexual health peer mentor panel for that retail setting.
Great, thanks so much. And Deja, you should be unmuted.
Hi, everyone. My name is Deja Cabrera. My pronouns are she, her, hers. I am from San Diego, but I'm currently in Florida. So yeah, there's that. I am transgender. I work at the San Diego LGBT Community Center, where I am the community health educator and advocate, and I am also a trans woman on PrEP.
Okay, thank you. And Blossom?
Hi, everyone. I am Coach Blossom C. Brown. I'm a PrEP retention navigator here in the great city of Los Angeles, California. I have been doing this work for many years. My pronouns are she, her, hers, and super grateful to be here.
Great. And Patris?
Hello, I'm Patris Bobia. I'm from Baltimore, Maryland, and I'm currently taking PrEP.
Wonderful. And last but not least, we've got Matt.
Hi, I'm Matt. I live in New York City. I'm queer. I'm 23, and I've been on PrEP since I was 18.
All right. Thanks so much. And we'll hear more from everyone soon. And just a reminder to folks that are not on the panel, please mute yourselves, and we'll be able to get to any questions and answers towards the end of the presentation. Okay, and here are our faculty's disclosures. This educational activity is supported by an independent medical education grant from Gilead Sciences. However, all activity content and materials have been developed solely by the planning committee members and faculty presenters. Here are our learning objectives for the day. Identify barriers to HIV prevention among cis and transgender women and among young people. Describe the impact of stigma on the mental health of people who are LGBTQ+, and discuss strategies to overcome barriers, specifically stigma, that lead to undertreatment and poor outcomes for at-risk populations. Okay, and of course we have a little test for all of you. So let's get to that. You will see some of these questions again towards the end of the presentation. Okay. Okay. And depending what you're viewing this on, you may need to scroll to see all of the questions. First one, I discuss routine HIV testing with my patients. Would you say never, rarely, sometimes, often, always, or NA? Maybe it's not applicable for you. Maybe you're not a healthcare provider. And question 2, how often do you consider PrEP for your cisgender and transgender women patients? Never, rarely, sometimes, often, always, again, or NA. And take your time, but I'll read aloud the last one. 3, which is I assess my LGBTQ plus patients for depression and other mental health conditions. Would you say never, rarely, sometimes, often, always, or NA? I'll give everyone a few moments to answer those questions. And I see your responses are pouring in. Thank you so much for answering these. They're very important. Okay, and we will go to our next set of questions. So these are some knowledge-based questions, again, equally as important. So one is Lori, a 34-year-old cisgender woman, reports sore throat and painful urination. When asked about her sexual history, Lori said that she had 3 or 4 male sexual partners in the past year and uses condoms sometimes. Should PrEP be considered for Lori, and why? Would you say no, because PrEP is not approved for cisgender women? No, because Lori's partners are men who have sex with women? Yes, because Lori has exposure to HIV through condomless sex? Or yes, because PrEP will help prevent HIV and other STIs? The second question is, which of the following is a contraindication to PrEP? Continued injection drug use, pregnancy, HIV infection, use of gender-affirming hormones, or all of the above? And we've got a couple more questions. People who are LGBTQ plus are approximately how many times more likely than the general population to experience depression, anxiety, or substance misuse? 1.5, 2, 2.5, or 3 times? And I'll read aloud the last question. Again, take your time. To mitigate stigma, clinicians should provide information about PrEP to which group? All men who have sex with men, all men in monogamous relationships, all sexually active adolescents and adults, or all LGBTQ plus people in non-monogamous relationships? Now, that was a lot to get through. We'll give everyone a moment to answer. And again, you'll have the opportunity to answer these questions again. And we know all of you will get 100%. And as you're taking the last few moments to answer those, I just want to point out one other special component of this webinar today. Towards the end, we're going to be breaking out into smaller groups, specifically a primary care group, an urgent care group, and convenient care. Dr. Robinson, Dr. Beringer, and Melinda will be representing those respectfully. And our panelists will be joining as well. So we ask that you choose the room that best aligns with your practice, or perhaps a room you'd like to learn more about. And if you're watching on Facebook, you may not have this capability. So you will stay in the main room if that's the case. And we'll meet back and we'll do our Q&A. Okay, we will enter a poll. Thank you so much, everyone. Okay, and we'll get the presentation up and then I will turn it back. I'll turn it over to Quentin. All right, Quentin, whenever you're ready.
All right, let's get started. Go ahead to the next slide. So as we set the background and kind of the baseline for tonight's conversation, we're just kind of look at the HIV epidemiology in the US. So overall, new diagnoses since 2008 has been on a gradual decline from about 43,000 to now 36,000 cases annually. However, when we look at the demographic groups that are most affected in terms of new diagnoses, most of those new diagnoses are occurring through sexual contact, primarily through male-to-male sexual contact, but heterosexual contact is also a method of transmission. Next slide. And when we look at how these new HIV diagnoses are broken down by both race and ethnicity, we do see that the majority of new infections are occurring in the age group 25 to 34, but there are some significant increases in the age group 13 to 24. And based upon race and ethnicity, we definitely see that the majority of those new HIV diagnoses are occurring in African Americans, with Hispanic and Latino populations following. Next slide. So when we talk about HIV, we also can't miss the opportunity to talk about STI. So the STI surveillance data from 2020 indicated that there were about 2.4 million cases of STIs reported in 2020. And of the STIs that we're looking at, gonorrhea, chlamydia, syphilis, all of them except for chlamydia have had significant increases since 2016. Of note, congenital syphilis, those are babies being born with syphilis, has actually increased by 234% since 2016. So definitely looking at what our STI data looks like, there is an indication that people are still having sex even through the pandemic. Next slide. All right, so now that we've kind of set kind of our background of what HIV looks like, let's talk about some specific groups of people who are at risk of exposure to HIV. So we're going to talk about cis and transgender women. Next slide. So when we look at HIV diagnoses among cis and transgender women, they actually contribute about 21% of all new HIV diagnoses. And we see that the rate of HIV new diagnosis has been relatively flat in both of those groups. Next slide. So when we talk about HIV diagnoses and the disproportionate effect amongst women and transgender women, looking at HIV diagnosis.
Hey, how are you?
I'm good. How are you?
Great, great.
21% of new HIV diagnoses actually occur in women, but however, women or those who identify as female are only 8% of PrEP users. Next slide. So as we talk about this and we think about this through tonight's discussion, what are some of these barriers for cis and transgendered women? Some of these barriers include that women may be unaware that their sexual partners have other partners, use injection drugs, or may not be using other harm reduction measures such as knowing their STI status, the use of condoms for sex, safe needle exchange and syringe exchange. But even amongst women, behaviors that increase their exposure to HIV, women still have low rates of testing. And we'll talk about what some of those barriers to testing are. And then specifically within transgendered women who may have a particularly high exposure to HIV and report high HIV testing and PrEP awareness, PrEP usage is also low. And we'll talk about how the ideas of medical mistrust, transphobia, concerns about drug interactions, and just the overall lack of access to quality healthcare contribute to these barriers to PrEP. So as we start this conversation, talking with Augustina and Melinda, how do you approach HIV testing amongst women? And what are some areas where you've encountered some potential resistance to testing?
So in my practice, testing for HIV is right along with testing for every other STI. If you're testing for gonorrhea, for chlamydia, you're testing for HIV and syphilis as well. And I think that some of the barriers, though, is that providers might think that, oh, because of women's transition, maybe rate is lower, maybe I don't have to worry about that. And that's what we're here to tell you, is that everyone needs to be screened for HIV, and everyone needs to have the conversation about PrEP, no matter what your setting is.
My previous practice, where I started an HIV prevention program, was in an urgent care setting, so not dissimilar to convenient care where Melinda practices. And so, people come not for routine primary care. And so, as Melinda mentioned, same for us. Anybody who comes in requesting STI screening for any STI we're going to have a conversation about HIV testing, right? Because if you have a risk that is concerning you about any STI, that means you also have a risk for HIV, and that naturally also opens the door to discussing PrEP.
Right. Fantastic. So in those conversations, just quickly, have you encountered any resistance to testing when you've offered an HIV test to a woman? Have they give you any potential reasons as to why they don't want to get tested? How do you approach those situations?
I have not outright experienced resistance to testing, but I will say that among the younger generation, there certainly isn't that fear of HIV that my generation, for example, had when in my college days in the 90s, early 90s. The HIV epidemic was causing terror amongst anybody who was sexually active. And I don't see that as much right now, which is wonderful. And it's a testament to the advances in treatment of HIV, but it can sometimes mean that people don't think about it as much. And so when I mention PrEP, that's where sometimes I encounter the resistance, like, whoa, you may be overreacting. I don't know, do I need that? Is this such a big deal? And the answer is yes, of course it's a big deal and you don't want to have it. So so not so much to the testing, but sometimes people are surprised by mentioning PrEP.
Right. Thank you for that. So you had a perfect segue into our next conversation. Next slide, please. So we're going to talk about youth and young adults, as Augustina mentioned, in terms of not necessarily having a lot of resistance to an HIV test being offered. So let's talk about HIV amongst youth and young adults. Again, people aged 13 to 24 contribute about 21% to the rate of new HIV diagnoses overall, even though there's been, again, a gradual decline from 2012, the advent of PrEP, up until our most recent data in 2020, 2019. Next slide. And again, looking at how PrEP is underprescribed to young people, again, young people account for about 21% of new HIV diagnoses, but they only account for 13% of PrEP users. So there's definitely an opportunity to have this conversation amongst young people. Next slide, please. So what's contributing to some of these, this disparity or discrepancy between HIV diagnoses and PrEP utilization? Part of it is actually the lower health care use by LGBTQ plus youth. Looking at a survey of sexually active young adults, most of them did not get needed medical care in the last 12 months. There's actually a need for increased medical care for STIs, family planning and contraception, and conversations around substance use. And one of the primary reasons why we saw that LGBTQ plus youth were not accessing healthcare was that they didn't actually want their parents to know either about the type of healthcare that they were accessing, or if there were conversations about their identity. Next slide, please. So again, those conversations about identity kind of leads us to our next topic around stigma. But before we get into that, I kind of want to pull some of our community in. So Matt, can you talk about kind of your experience in terms of, briefly accessing healthcare as a young adult?
Yeah, hi. Well, so I first got on PrEP, like I said, when I was 18. which was 5 or 6 years ago. And that was when PrEP was still, I mean, it's still new to the market, but it was really new to the market then. And I was a senior in high school preparing to become sexually active, and I had heard about it from like the internet. And I told my parents about it and went to my pediatrician. And I asked if I could go on this medication. And in doing that, you know, it was kind of a funny trip to the doctor, because in doing that, I had to explain to my doctor that I was gay. And she was so sweet, but she like, you know, reached out and like took my hand and was like, "You're loved and I accept you." And I was like, "That's great, but that's not why I'm here. I'm here because I want this medication." And then she didn't know what PrEP was. So I ended up having to explain to my pediatrician what PrEP was so that I could get it prescribed. Which,
thank you. Oh, so Matt, I think that's a fantastic conversation, and I definitely think we can definitely delve into that a little bit more.
Talk that later.
Yeah, and definitely in the
Okay.
breakout sessions. I just want to get an idea of like when you're accessing healthcare in general. But thank you, that was a perfect segue into our conversation about stigma. So next slide, please.
Yep. And I'm just going to jump in, Dr. Robinson. I know that we've got hundreds of folks on here, which is just amazing. As most of you are probably familiar with Zoom, there are so many different settings and views. So if you would just like to see the speakers, you can go to view, select that, and then select side-by-side speaker. So you're probably not seeing everyone. Again, totally up to you. I just wanted to mention that.
All right. So thank you, Rachel. So now we're talking about stigma as a barrier to healthcare. So as we start this conversation, I like to set these kind of background information. There's this intersection of HIV and some of our social determinants of health, poverty, access to healthcare, access to food insecurity. So looking at this map here, we see that in the darker blue, those are states where there are households that are below poverty level. Next slide. And looking at this animation, you can see there's a similarity in the increases in new HIV diagnoses in those states that have higher households living under the poverty level. And so the South actually accounts for over 66% of new HIV diagnoses among Black individuals, and for 42% amongst Hispanic and Latinx individuals. So again, the majority of the Southern United States, like Georgia, where I am, a lot of households are below the poverty level, and those same states actually have the highest rate of new HIV diagnoses. Next slide, please. So when we talk about HIV risk, and these are our populations that are significantly exposed to HIV, in the US, the overall lifetime risk of HIV is about a 1 in 20. Looking at white males, it's about 1 in 171. White females' overall lifetime risk of HIV is 1 in 874. But when we talk about those groups that are at highest risk, Black males overall, their overall lifetime risk is 1 in 27. Hispanic males, 1 in 50, and Black females are 1 in 75. And that's your overall lifetime risk if you do nothing to mitigate their exposure to HIV. So there's definitely some significant conversations to be had. Next slide. So who's using PrEP? Again, looking at our map and our data, 42% of new HIV diagnoses occur in Black people, but the overwhelming percentage or the overwhelming majority of persons using PrEP are white. So what can we do to mitigate this disparity here? Next slide. And how does stigma contribute to this? So just give you an idea of kind of setting where we are with stigma. Stigma is a social determinant that may be more readily immediately addressed by healthcare providers. Stigma exists in different settings. The lack of cultural humility or cultural competence contributes to stigma. And this then leads to denial or refusal of healthcare services. Verbal or physical abuse are experienced by sexual and gender minorities. Next slide. So what we found in a survey of around 1,600 LGBTQ plus adults, 15% of them actually avoided medical care because of disrespect or discrimination. And looking at those groups of those within the LGBTQ community, the majority of the ones who are experiencing stigma tends to be those of trans experience, either avoiding preventive screenings, experienced discrimination for a doctor, or had to teach providers how to get the treatment that they needed. Next slide. So how is stigma a barrier to healthcare? It impacts the individual's perception of their risk because of a stigmatized condition. It limits their willingness to seek HIV testing or prevention services. It affects their adherence and persistence to prescribed therapies. And then those barriers of stigma around HIV and sexual and gender identity can then be further emphasized because of racism and other stigmas such as substance use. Next slide. So how does all of these ideas of stigma and these different ways people feel stigmatized affect their mental health? Next slide. So talking to specifically Deja and Blossom, how has stigma within the healthcare setting affected your physical and mental health?
Yeah, I'll go ahead. Yeah, as a Black trans woman, it took a toll for sure. I couldn't go into certain spaces without feeling discriminated and feeling, oh wow, bringing back a lot of memories. But it took a toll on it, and I had to learn how to navigate, because as a trans woman, being in survival mode is kind of my thing. I've learned how to navigate in the survival mode, especially in the healthcare setting. And so, yeah, that was kind of a little bit of my experience.
Yeah, I'd say the same for me as a Latin trans woman, the machismo that is in my community is stressful. You know, we're not allowed to show emotions. We're not allowed to cry, you know, and, you know, I think just the idea of being a man and the pressures of that, and then feeling the feelings that I'm feeling of being a woman and, you know, being fish and femme and, you know, living my best life, but also going into a society that does not see me as that yet, is hard and challenging. And when you go to these professionals that are supposed to help you, and they don't help you, or they look at you like you're weird, or they look at you like you're their next science project, it's like, okay, I guess I got to roll with the punches. So it's definitely difficult.
Thank you for that.
And Quentin, if I could jump in, I just want to also clarify that we're not just talking here about healthcare providers who are intentionally discriminatory or evil in any way, right? A lot of the experiences that our patients have that are less than pleasant and less than helpful, to say the least, are just out of ignorance. And so it is upon each of us to educate ourselves to serve the communities that we serve and to serve the patients that we take care of.
All right. Thank you. Thank you for that. All right, next slide. So when we talk about mental health concerns within people who are within the LGBTQ community, they're more than twice likely to have a mental health disorder and more than 2.5 times more likely to experience some form of depression, anxiety, or substance use, which is a very important point. 2.5 more times likely than the general community. Next slide, please. And so how do these social determinants affect the health of our LGBTQ individuals? You know, the evident one is that there is a shortage of healthcare providers who are both knowledgeable and culturally competent in LGBTQ health, understanding the nuances of the communities in which they're taking care of people and working within those communities to understand language and customs that may be particular to those groups. Next slide. So now that we've kind of talked about what HIV looks like in the United States, who's affected by it, what are some barriers that are existing between, you know, women, young adults, how all of that impacts people's overall mental health, let's talk about how we test and prevent HIV. Next slide. So the first thing is, how do you ask the questions? You know, you can set the stage, you can use gender and sexual orientation neutral language. When you ask about how someone's having sex and who are their sexual partners, you don't necessarily have to say, hey, are you gay or straight? Do you have sex with men, women, or both? Use open-ended questions and be straightforward and sensitive. Like, tell me about your sex life. Who are you having sex with? How do you have sex? And allow the patient to kind of generate that natural flow, and that show the patient that you are both comfortable and willing to listen, and make the patient comfortable enough to be sharing their details of their intimate life. Next slide. So when we talk about the knowledge of HIV status in 2019, 13% of people with HIV do not know their status. Again, that's 13% of people who are living with HIV are not aware that they are living with HIV. But those rates are even higher for younger people. 44% of people between the ages of 13 and 24, and 24% of people between the ages of 25 and 34 are not aware of their HIV status. So that's definitely a conversation we should be having. Next slide. And when you approach HIV testing, approach it from a status neutral care continuum, which is you start with an HIV test and you have two ways to go. The HIV test is negative. You have a conversation about prevention methods and PrEP, continued participation in care. You then reduce their risk of HIV and you repeat their HIV test. On the other side, you start with an HIV test. If that test is positive, you have a conversation about treatment. You get them linked to care, you keep them in care, and you maintain their viral suppression, and you again decrease the transmission and risk of HIV. Ongoing maintenance and support and engagement with the healthcare system is crucial in a patient, whether they have a positive or a negative HIV test result. Next slide. So the current guidelines of HIV testing, who should we be testing and how should we be testing them? So the old thought of targeted testing based on risk categories, i.e. this person has sex with multiple partners, or this person is having sex with a man without a condom, you'll still miss about 20% of people living with HIV. The United States Preventive Services Task Force gave the grade A recommendation of screening all adolescents and adults aged 15 to 65 at least once a year, or at least once in their lifetime, for HIV. And then repeat screening is reasonable for people with potential increased exposures, sexually active adolescents and adults, and anyone who comes in asking for an STI test or an HIV test should get an HIV test. Next slide. So specifically talking about screening for HIV, laboratory-based testing is your standard method of testing. An antigen antibody test, if it is not a rapid test, you must bring the patient back for their results. Rapid tests are extremely advantageous. You get results within minutes, and then it increases your access to prevention and or intervention, i.e. linkage to healthcare services, and they're easy to administer, whether it's from a blood draw, from a finger prick, and then or even an oral swab in terms of HIV testing, which oral swabs have kind of fallen out of favor, but it's still a fantastic way of testing. But your HIV rapid test may miss recent or acute infections. So again, as clinicians and even as community, be aware of the signs and symptoms of acute HIV infection. If someone presents with a headache, fatigue, myalgia, sore throat, fever, or swollen lymph nodes, and has had a recent potential exposure to HIV, that's a perfect time to talk about alternative methods for HIV testing. And so here's an opportunity to just kind of talk with the community about what their experiences have been with HIV testing. Patris, what's your experience been with HIV testing?
So mine was pretty easy because you know, I tested positive for 2 STDs. And so once I tested positive for that, they pretty much, you know, they told me that they was going to test me for everything, which I was okay with. And then my HIV test came back negative. And, you know, that's when they introduced me to PrEP.
All right, thank you. Next slide. So who needs to hear about PrEP? All sexually active adults and adolescents should be informed about PrEP, primarily because a lot of times patients don't disclose their sexual or substance abuse behaviors or increased risk behaviors for HIV to their healthcare providers. Next slide.
Quentin, could I interject to the
Sure.
point of disclosing sexual behaviors and other behaviors to healthcare providers? This is where urgent care and convenient care things can go one of two ways. Either people don't know you, and so they're less comfortable disclosing things, and so you have to ask things in a very specific way. Or sometimes people feel more comfortable speaking to a provider that they may not see terribly regularly, that is not, as Matt mentioned, their pediatrician from their whole life, or especially for younger patients. I don't know your mom. I'm not going to tell your mom that, that you were asking these questions or that you were looking for these tests. So it's important, even if you're in a setting where you think, well, this is sort of like a one and done visit, it's important to address these things, because you never know. Patients have opened up to me with things that they've told me they don't feel comfortable sharing with their primary care provider. And then sometimes the opposite is, of course, as well the case.
All right, thank you. So when should you consider PrEP? When a first opportunity is when a patient requests PrEP, even without disclosing a specific risk. If someone comes in asking for PrEP, that is when you have a conversation. Other opportunities are when people come in for STI testing, or they presented to you with a request for frequent STI testing or treatment. If they ask about HIV testing, if they disclose to you that they have had multiple sexual partners, sexual activity in high prevalence areas, going back to our first conversation, where 66% of the new HIV diagnoses in the United States occur in the South. So if you're a healthcare provider in the South, you probably will want to have a conversation about PrEP with the majority of your individuals there. And the only contraindication, the only reason why you would not start someone on PrEP is if they are coming in with a new HIV diagnosis. And at that point, that's when you would link them to HIV care. So there really isn't a reason to not start someone on PrEP if they're interested in it. Next slide. So PrEP effectiveness. So does really, taking a pill or getting an injection decrease your risk of getting HIV? The answer is yes. Oral PrEP reduces your risk of HIV acquisition from sexual exposure by over 99% when taken as prescribed. And it also reduces the risk of HIV amongst people who inject drugs by at least 74% when prescribed. However, it does not protect you against other STIs. So those conversations about syphilis, gonorrhea, and chlamydia and screening and testing must occur. Next slide. So what are your options for PrEP? You've talked to someone about PrEP, they're interested in PrEP, you've done an HIV test, they're negative. What are your choices? So you actually have three options now. You have oral PrEP, which consists of Truvada or Descovy, which are branded drugs. Tenofovir TDF was the first drug approved for PrEP in 2012. Anybody with normal functioning kidneys, there is a small risk of kidney or bone toxicity with the drug, but it's approved for all at-risk populations, and there's generic forms available. The other drug is tenofovir alafenamide, or TAF, T-A-F. That was approved in 2019, and is actually approved in people who have somewhat compromised kidney function, and it remains effective. It has less bone and kidney toxicities. However, it's not indicated for people who are at risk of getting HIV through vaginal intercourse. There is, ongoing potentials for clinical trials looking at the use in those populations, and it's a smaller pill. Your third option, next slide, is injectable PrEP, which is Apretude, which just got FDA approval this year, or cabotegravir. It's an injection that's done in the clinician's office every 2 months. Compared with oral PrEP, it has a 69% lower risk of HIV in cis men and trans women, and a 90% lower risk of HIV in cisgendered women. It's been approved for use in all populations. It has minimal drug interactions. Common side effects are injection site reactions and fatigue. They're really, are fantastic options for people. You have the conversation, they can choose oral or injectable PrEP. Next slide, please. So can you initiate PrEP on the same day that you see someone? You know, for Augustina and Melinda, in urgent care and convenient care settings, sometimes that's your perfect opportunity. You're not sure if you can engage this person to bring them back. So can you start someone on PrEP the same day? If you're interested in doing that, your clinic must be able to conduct point of care HIV testing. Ideally, get in HIV test and get the results back within that same day. Oral fluid should not be used in testing for rapid initiation. It must be a blood-based test. Draw blood for kidney function and additional HIV testing. If there's kidney dysfunction or there's a positive HIV test, you should be able to connect and follow up with them quickly. And then your clinic should be able to provide scheduled follow-up care, and contact with patients if labs indicate the need to discontinue. If you're unable to provide ongoing care, be aware of the resources in your community that are providing PrEP and link a patient to a provider who can. Next slide.
To interject that for 1 second, Quentin. On that same day PrEP, if you have a serum or a blood rapid test and you're in convenient care and you want to start same day PrEP, you have a pharmacist right next to you who is a great resource. So not only can you do the same day PrEP, you can consult with the pharmacist to make sure, okay, what do you have in stock? What can I give them today? What's in their insurance network? How do I get them the resources if they don't have insurance? So really utilize that pharmacist to help you get this off the ground.
And even with the, so to address a question in the chat, I do want to clarify that Apretude was proven to be 69% better at preventing HIV than oral PrEP. So I can't do the math to tell you. So no, I think instead of Truvada, so it's better than Truvada, right? So, sorry. Back to Melinda's point, in urgent care, we don't necessarily have the pharmacy right there, but we have the point of care. Fourth generation labs, very important that they be antigen antibody tests. And even if you're giving oral PrEP, if you're giving Truvada and you want to make sure the patient has a normal creatinine clearance, for my urgent care, that test came back the next day. I'm probably not going to kill someone's kidney with one pill of PrEP today if tomorrow I find out that their creatinine clearance doesn't support Truvada and I have to move to Descovy or possibly injectable. So you are completely right, Quentin. We have the patient right there. They're interested in starting. I'm starting them unless they have HIV already.
I'm so sorry. I have to bring this into the conversation because in some places, same day PrEP may not be available. And what I've seen a lot of clients do is actually go to PEP whenever they think they've gotten an exposure, take it for 28 days and then transition over to PrEP because ultimately those resources may not be available right away. And ultimately what I do is I do refer clients to urgent care because sometimes the process is a little bit less draining than it is working in a clinic, than in an actual clinical setting.
Yeah, thank you for that, everyone. And Blossom, you're exactly right. So with this slide, this is specifically for those clinics that, giving them guidelines in order to, do same day PrEP, but you're exactly right. The conversation about post-exposure prophylaxis, so this is after someone has potentially had an HIV exposure, is a fantastic opportunity for urgent cares, emergency rooms, and convenient care to provide post-exposure prophylaxis, but then still have a conversation and, facilitate a transition to pre-exposure prophylaxis with PrEP. So thank you for that, because it's true, we do not talk enough about post-exposure prophylaxis as a prevention method for HIV. Next slide, please. So now you've considered prescribing PrEP. How do you follow the patient? Like, what are your next steps? How hard is this to do? It really isn't difficult at all. If you've started someone on oral PrEP, you're going to see them every 3 months. And at those every 3-month visits, you're going to prescribe, you're going to take an HIV test, you're going to talk about signs and symptoms of acute HIV. You're going to ask them, are you taking your pills every day? How are you taking your pills? Are you missing any pills? You're going to screen them for bacterial STIs like syphilis, gonorrhea, and chlamydia. And you're going to test whatever parts of their body they use for sex. So we talk about 3-site testing. oral, rectal, urethral, or vaginal. And then other labs, you may consider checking their kidney function and their cholesterol. If you're considering injectable PrEP for someone, you're going to do the same things. You do it a little bit more frequently. You're going to see them every 2 months. Because there's no need to count pills or ask how many pills they're taking because they've had, a depot injection that lasts for 2 months, you don't necessarily have to assess for adherence. But the basic idea here is that you're going to see these patients frequently, and you're going to screen them for HIV and screen them for STIs and talk about their sex life every 2 to 3 months. Next slide.
And I just want to jump in, Dr. Robinson.
Yes.
I know that we've got some questions, and Diana in the chat had asked about urgent care. So urgent care, and we don't have to answer this right now, but Diana, we're going to be breaking out into, and for everyone, into some breakout rooms, a primary care room, and urgent care, and convenient care. So we definitely encourage you to select that appropriate room, and then we'll come back for other questions and answers.
All right, thank you. So I did see a quick question in the chat that I think is important. So someone asked about long-term side effects. So prescribing daily meds without understanding, so someone has a question about the long-term side effects because they don't like to prescribe medications unless there's a strong benefit. Here, I think we've demonstrated there is a strong benefit to decreasing someone's acquisition of getting HIV. So I think that's one, there is a strong benefit to prescribing a daily medication. However, these are medications that we have at this point years of experience with on the treatment side. So in terms of overall long-term side effects, there really isn't a big difference between oral PrEP and those who are using those same drugs for treatment of HIV. So there is some data about that. So now that you've screened someone, you've talked about PrEP, you've gotten them started, how do you get them drugs? Most insurance plans and state Medicaid programs and Medicare cover PrEP. A prior authorization may be required. Ready Set PrEP is a federal program that provides PrEP to people with no prescription drug coverage. For those who have commercial insurance, there is copay assistance, Gilead advancing access for oral PrEP, ViiV Connect for injectable PrEP. Some states have PrEP assistance programs, and your documentation status, whether you are a documented immigrant or not, is not a factor in your eligibility for PrEP. Thank you. We definitely have an opportunity for questions and answers. I know Rachel has a post-test, and we have some great conversations to have in our breakout rooms. So turn it back over to Rachel.
All right. Thanks, Dr. Robinson, and thanks to all the presenters. Really appreciate it. So as we promised, we do have those post-test questions that we're going to ask, so we'll get through those quickly, and then we'll do the breakout rooms, and then we'll come back here for the Q&A. Okay. So you've seen these questions before. First question, Lori, a 34-year-old cisgender woman, reports sore throat and painful urination. When asked about her sexual history, Lori said that she had 3 or 4 male sexual partners in the past and uses condoms sometimes. Should PrEP be considered for Lori, and why? No, because PrEP is not approved for cisgender women. No, because Lori's partners are men who have sex with women. Yes, because Lori has exposure to HIV through condomless sex. Or yes, because PrEP will help prevent HIV and other STDs. And just make sure you scroll down to see the other questions. 2, which of the following is a contraindication to PrEP? Continued injection drug use, pregnancy, HIV infection, use of gender-affirming hormones, or all of the above? And our third question is, people who are LGBTQ+ are approximately what times more likely than the general population to experience depression, anxiety, or substance misuse? I'm expecting 100% on this. I think Dr. Robinson called this one out a couple times. 1.5, 2, 2.5, or 3. And our last question, to mitigate stigma, clinicians should provide information about PrEP to which group? All men who have sex with men, all men in non-monogamous relationships, all sexually active adolescents and adults, or all LGBTQ plus people in non-monogamous relationships? Give everyone a moment to answer those questions. Okay, we'll give everyone just a few more moments. And as you're answering those, just a reminder, our breakout rooms are as follows, and you'll be able to choose the room that you, whichever you'd like. So our primary care room will be Dr. Robinson, Deja, and Stan from my team. For the urgent care room, it will be Dr. Beringer, Patris, and Ashley from my team as well. And then for convenient care, we've got Melinda, Matt, Blossom, and Samuel from my team. Okay, and we will actually look at these responses. Okay, we'll go through these. So first question, it looks like most folks said yes, because Lori has exposure to HIV through condomless sex. Dr. Robinson, how did they do?
So fantastic, 86%. So you were listening.
Okay, question 2. Most 68% said HIV infection. How did they do on this one?
We did great, 68%. I definitely think we need to think about like who, a question will be who not to use PrEP in. And the only group that you should not use PrEP in is in someone who has HIV.
Okay, and question 3. I don't think we were all paying attention. The correct answer is we're a little split.
Yeah, so it's somewhere between 2.5 and 3%. The correct answer is 2.5. So the majority of you all got it correctly at 52%.
Okay, and our last question, and thank you all so much. It's great information that we could take back and help when we develop future activities. So our last one, 91% said all sexually active adolescents and adults.
Fantastic. So we for me as an HIV provider, I think that's great that you all recognize that clinicians should talk to every sexually active adolescent and adult about PrEP. So I think 91% is fantastic. Kudos to you all.
Okay, wonderful. Okay, so at this point, I will open up the breakout rooms. And like I said, you can choose whichever room you would like to be in. So let's open those up now. Okay, is everyone, and feel free to turn your cameras on at this point. Our panelists and moderators in the room would like to see you and hear you in those rooms. And I see folks are slowly going in the rooms, which is wonderful.
How do I switch rooms?
Sanjita?
Thank you, Ted. Yes, I don't see an option. It didn't come up for me.
Okay, which one would you like to be in? I can assign you.
Primary care.
Okay.
Oh, same with me too.
Same with me too.
Me too.
Me as well.
Me too.
Me too.
Did anyone get a pop-up?
Me too.
I didn't get a pop-up.
Breakout rooms. It'll show you the rooms.
Well, I think you need to click on the numbers. So it show the join option.
Yeah, does anyone see the option? If not, we can start putting you in some rooms.
I don't have a number. I don't know.
If you click on where it says breakout rooms at the bottom, it will pop up something that you can say.
Thank you.
Yeah, right.
I don't remember which one was which. Got it. Thank you.
If not, I will we'll just assign you to some rooms.
Just assign me. This is Lorraine.
This is Pat Bowman.
Sorry.
Rachel, would you assign me, please?
Oh, goodness.
Sure.
Wes, I'm in a meeting. Oh,
I can't get in.
Gotta hit that more thing.
They're getting some requests from third parties.
hi, Lorraine.
Hi.
Hi.
Getting either.
I'm trying to get to
Dan, I've assigned you to primary care. I think he's gone.
Can you assign me to where?
Can you assign Pat to emergency medicine or urgent care or whatever?
Okay, folks, I'm assigning everyone. You should get a pop-up about a room.
Breakout rooms, okay. Urgent care. Assign myself.
And Faith will do so as well.
I'm doing that too. Yeah, for anybody who is able to see at the bottom, there should be a button that says breakout room. If you click it and you scroll down, you should be able to join a room. But if not, like Rachel said,
And for folks that haven't been assigned yet, you might need to increase the size of your Zoom window. Sometimes it gets cut off. You should see breakout rooms at the very bottom or more. And sometimes if you're on your phone, it's not as easy to spot. And it looks like everyone's assigned. So Ava, Con, and Pat, you should have, if you weren't able to before, you should be seeing a message for you to join those rooms.
hi, Rachel. Where's my, oh, you're muted.
Hi, Faith.
I don't know what just happened. I went to go assign someone to urgent care and it put me in there. And then when I tried to come back,
I wonder if I put you in there by accident.
that would make a little sense. Okay.
I know some folks that are just joining us. I'm not sure if you were in our main presentation a few moments ago, Fatima, Orlando, Cassandra. We are breaking out into smaller groups right now. That's why you see such a few of us in here. So we have the breakout rooms open, and feel free to choose whatever room you would like.
Rachel, this is Pat. I can't get into primary care.
All right, Pat, why don't I?
This is Pat Thoman. I got into urgent. I think there were a couple of Pats that requested help.
Let's see. No, wait, you're not in unassigned. Let's see if I can move you back in there, Pat.
Yeah, and it's in front of me, all the attendees, but I can't get rid of it here. Okay.
Faith, can you look into that? Pat should be able to go back into another room. And you're muted, Faith.
Can you make me a co-host again?
Absolutely. Okay.
Okay, let's see. So let's see. I'm looking.
And I am just going to pop in the other rooms. I will be right back, Faith. Pat, you're in good hands with Faith.
Oh, thank you very much.
Let's see. Pat, what room were you supposed to be in here?
Primary.
Primary.
I was put into urgent.
Oh, okay. You were booted into urgent, you said. So let me find you there. I'll unassign you from there. And then we'll find you on. Let's see. Thank you for being so patient with us here.
Oh, no, that's fine.
I'm going to move you to primary care, okay?
Oh, great. Thanks.
Hi, Linda. Should I assign you to any specific room?
Primary care?
Okay, let me migrate you over there now.
Thanks.
Hi, Cassandra. Oh, hi, Cassandra. Should I migrate you to any room right now? We have primary, urgent, and convenient care. Feel free to say in the chat too, and I'll be happy to move you there. Cassandra, I'm happy to assign you to urgent care, primary care, or convenient care, whichever you'd like. Just let me know which.
Primary care.
Perfect. Thank you so much. I will do that right now.
I am back.
Great.
Did we lose Pat, or is she?
Nope, we got her to her grateful home.
Thanks, Faith. Yeah, some big and hi to the folks streaming on Facebook that are unable to get into the breakout rooms. It's really just for Zoom only, but we will have this available on demand so you can check out what was discussed in the breakout rooms. And I will pop back in again, Faith.
Great.
Thanks.
Hi to everybody who has joined me here. happy to assign you to either a primary care, urgent care, or a convenient care room. If you just let me know which one, either with your microphone or in the chat, I'm happy to move you wherever you'd like. Okay, let me move you over to primary care right now. And Doris, I'm happy to move you wherever you would like, primary, urgent, or convenient care. Hi, Evelyn and Doris. I'm happy to assign you wherever you'd like. Either primary care, urgent care, or convenient care, just let me know and I'm happy to migrate you. Otherwise, you can take a break with us. Hi, Richard. I'm happy to move you to whichever room you'd like. We have, oh, we lost him.
Got some more folks, and I'll come right back, Faith. And to everyone watching on Facebook, you can take a few minutes break. We're just doing our breakout sessions live via Zoom, and we'll be with you shortly. Hi, folks. I know that we're coming back in, and we want to get to the Q&A. We'll, I'm sure some of you were in the middle of answering or asking some questions, so we will get to those very shortly in the Q&A. I don't know if we anticipated such a large group, which is it's actually a great problem to have. So absolutely. I know some folks are still trickling in. Okay, as long as we've got Dr. Beringer, I see her. Melinda, hi.
Hi, I was, that person who I was talking to just now is back online. You can send me, is it okay, Rachel, if I put my email address in the chat if anybody wants to reach out to me? Okay.
Yeah.
I'm going to put my contact email address in the chat if anybody has any questions about PrEP, retail, primary care, if somebody wants to reach out.
That's a great idea, Melinda. I'll follow suit and I'll put my email address in the chat as well.
Great. And then
I'm on the bandwagon as well.
We've got a bunch of questions that people had asked me directly, but I just want to ask Dr. Robinson, Melinda, and Dr. Beringer, any questions that you didn't get to address that you wanted to in the breakout sessions? We can start with those.
I was just wrapping up the contraindications for PrEP and explaining why HIV infection is a contraindication, and just wrapping up the explanation that PrEP would not be full treatment for actual HIV. So you do run the risk of developing a resistant strain of the virus if you're only partially treating it by giving PrEP if they already have HIV. So that's why it's so important to do those fourth generation tests and every time they come. And somebody had asked also if you also do the 3-site testing every 3 months when they come in for oral PrEP, and the answer is yes, because they're there. Why not? Let's make sure they don't also have, chlamydia, gonorrhea, or anything else.
And to piggyback on that with the 3-site testing, so I also do 3-site testing in my female patients as well. So the University of Washington has fantastic guides on self-collection of oral swabs, self-collection of rectal swabs, and self-collection of vaginal swabs. You don't necessarily have to have I haven't done a pelvic exam in ages, but a speculum to do a cervical exam. Your patients with a vagina can actually do their own swabs. Or you could screen them with a urine. It's depending on the person's comfort, but we're looking at oral, rectal, and genital areas in terms of your 3-site testing.
That's right. Gay men are not the only people who have receptive anal intercourse, correct? So wherever people have sex, there can be a swab. And I would usually just, for comfort reasons, just say to the patient, sometimes the throat, they don't like to do themselves because they'll stop before they get to where it needs to go. But here's the cup and the swab, go in the restroom, give me a little urine and do a rectal swab and then just bring it out. Easy peasy.
So there was another question in the chat that I thought was a really good one. So clearly someone's read the 2021 CDC PrEP guidelines. So thank you for that. It's true, the current guidelines do recommend doing viral loads on PrEP patients in addition to 4th generation testing. That is a new recommendation in the guideline. It's primarily coming out of the data looking at injectable PrEP, where there were a few missed cases where people had gotten an injection, but they also had really early HIV infection that was before antigen developed and before antibody developed. So anything that will decrease the potential of giving someone with HIV a preventive medicine and linking them to care as an option. You can do both a blood-based viral load. If you're looking at kidney function, if you're drawing a tube for an RPR, you can add a RNA, a PCR to that as well, and do your 4th generation as well. So it is just an additional layer of screening patients appropriately and making sure that they're HIV negative. I don't perceive that as a barrier to access to PrEP, but I think that's a great point to bring out because that is in the guidelines.
And to that point, and also to address here a question from Dr. Collins, a pediatrician, this also came up in our small group, PEP and PrEP, right? There's a big difference. So if somebody had a recent exposure and you're concerned that they may have just gotten HIV or been exposed to it, now is not the time for PrEP. Now it's time for PEP, for post-exposure prophylaxis, which is a 3-drug or 2-medication regimen. That's where that second medication comes in to avoid the risk of developing a resistant strain. And then that is a 28-day course. You bring them back, you test them again. Hopefully you did everything with your drugs that they did what they needed to do with the drugs and they didn't seroconvert. And then you can convert them or switch them to PrEP, which is 1 drug orally every day, or the injection every couple of months, every 2 months.
Yeah, and that's great information, Augustina Deboringer, to talk about that a little bit more about Dr. Collins' question. So if they're not a candidate for PEP, I think 100%, you have to make sure they don't need PEP. If you're doing PrEP, really for a 14-year-old, it's the same guidelines. You just have to make sure that they weigh more than 35 kilograms. Most 14-year-olds do. That's it. The question about do you need parental consent, it depends on where you live. If your state says that they can't be seen for sexual issues and they're 16 until 16 or up, then you need parental consent. If you're in Illinois, and I think it's 12, then you're fine. So the parental consent goes by what state you live in.
Yes, when I was practicing in Massachusetts, anybody, I believe it was age 13, could have been 14 or over, could make their own decisions about sexual reproductive health, except for surgery, surgical sterilization, or abortion. And so not only did we not need parental consent for those patients, but there's also an act that states that health insurance that is under a parent or another, guardian, does not need to list in the explanation of benefit what the patient saw you for if it's regarding matters of sexual and reproductive health. So that 14-year-old's parent is not going or shouldn't get an explanation of benefit that says they saw Dr. Collins for PEP or PrEP or STI testing. It should just say the visit.
Right. I mean, of course, there is this big question of the age. We're just specifically talking about right here if whether or not they're appropriate for PrEP or PEP, or what the guidelines are for someone who's 14. Of course, if you're their provider, you have to wade through that whole, if it is non-consensual, consensual, if they're over 24, that's a huge issue. But we're just keeping it to what they're the medical part of if they're appropriate for PrEP or not.
So there were two other comments or questions that I thought were fantastic. One, how long after exposure to HIV can PrEP be given? You have a 72-hour window for post-exposure prophylaxis. So someone has been potentially exposed to HIV, there's a 72-hour window for post-exposure prophylaxis. And the other one, which is a fantastic one that I actually encountered in my practice, PrEP in the geriatric population. People, I use it as the other little blue pill. I had an issue where a patient who lived in a high rise, he was 65 years old. He came in with an STI of gonorrhea. And I proactively had a conversation about PrEP with someone who, came in with an STI. The other thing was I had a conversation with another primary care provider who says, I primarily see geriatric patients. They're not having sex. I was like, well, have you ever written a prescription for Viagra for any of your male patients? He was like, of course I have. Then I was like, then you should have a conversation with them about PrEP. So you're exactly right. We definitely don't want to forget our geriatric population because they are extremely active. And that's another group you can talk about using PrEP in.
There's another great question, Quentin, maybe you can address this. Not talking about on-demand PrEP, which somebody had mentioned in the chat before, but what is the time frame from when you start PrEP until when you are protected, essentially?
So in terms of when to start and how long do you have to be on to be protected, the data vary, and it varies between what type of sexual activity you are involved in. So the general consensus is that we usually tell patients somewhere between 7 to 14 days of daily PrEP, you will be at a point where you would be decreasing your risk of acquiring HIV. So
I also want to jump in on that because women do not have much grace as men when it comes to missing doses. Men usually, what I tell my male clients is they have about 3 days that they could miss before they have to start over, and that protection builds back up within those 7 days. But with women, they have at least about 2 weeks, if I'm not mistaken, where it has to build up in the vaginal wall, if I'm not mistaken.
Yeah.
Correct. Okay, I just want to make sure. Yeah.
For women having vaginal intercourse, it does take a little bit longer to build the levels in the vaginal tissue. That's a great point. Angel, yes, PEP is what you want for a nurse that's been exposed by a finger stick. Absolutely.
There's another question from Antonio, who's a PA, about patients falling through the cracks if they utilize online services for PrEP. So yes, amidst the COVID pandemic, a lot of online and teleprep services became available. I actually don't think that patients are actually falling through the cracks if they're utilizing those services, and those services are being administered appropriately in terms of, the number of refills, if you're getting screened for STIs appropriately, and, and HIV testing. I only have experience with 2 of them, and I'm not going to give them any free advertising, but I do know that they limit you to 90 days. You get your 3-month supply. They send you your own home testing kit in which you do your own self-collection of oral, rectal, and urine samples, and you do dried blood spots in terms of you prick your finger, drop a couple of drops of blood on a little card, and you mail that into a lab, and they do your kidney function and your HIV testing based on the dried blood spot. So if the prescriber within those online programs are utilizing those services and the patients are utilizing those services appropriately, I don't think many people have fallen through the crack with that. So it's again yet another option that we didn't include in here in terms of talking about teleprep or mobile prep services that are available.
I need to push back on a little bit of that, because during the pandemic, because I was one of the ones that was working with the prep clients all through the pandemic. And what really happened was in our clinic, the clients still actually did have to come in and do labs, but they could do their telephone appointment over the phone. We were not accepting any clients to come in person to do face-to-face with the provider. So with a lot of those clients, they did fall through the cracks. And PrEP retention, I need to really name this and bring this into the space, because on one of those slides, when we were talking about HIV positive folks and HIV negative folks, we were talking about HIV retention over here. And on this side, we were talking about continuous participation. Well, my job is PrEP retention in PrEP, because how do we keep clients empowered to stay on PrEP? What do we do? Like for us, we did campaigning to show the community. We did risk assessments to keep people engaged, to keep up with the data. And so PrEP retention is very, very important when it comes to PrEP, because how do we keep people on PrEP? Because ultimately, yes, PrEP is a choice, but what's also happening is in these communities where a lot of Black and brown folks are, because they are the targeted population, they may not want to be on PrEP just because they are the targeted population. And a lot of stigma forms in those communities. And I have seen it so many times with these clients, especially when we do outreach. And so that's very, very important that we name into this space.
All right. Thank you.
Awesome. And Dr. Robinson, we've got a question I just sent to you that some folks had, but I just wanted to mention, we're going to put the link to the evaluation where you can claim your CME and CE credit in the chat. I know that we've got tons of folks that have stuck around past our 7:45 Eastern end time. So we'd like to continue this till 8 Eastern, since all of you are still here. So Faith is going to put that in the chat, and then we'll get to the question. But I just want to remind you, if you're new to DKB Med, you'll be asked to create an account. That will be very quick and easy. You'll have to do that in order to claim your credit. And again, if you have any questions, feel free to let us know. And like I mentioned at the beginning, these slides will be emailed to everyone, so you'll have access to those. Dr. Robinson, that question was, how do you recommend engaging and encouraging young people ages 13 to 24 to take PrEP?
All right, thank you. That's a great question. I'm definitely going to ask for some assistance from Matt as well. I don't see patients younger than 18, so I don't have the experience with that particular group. But in terms of, for me, it's have the conversation about having sex. If you are having sex, one of my questions is always, so you're sexually active, what are you doing to decrease your risk of getting HIV? So instead of introducing and saying, I want to put you on PrEP, I want them to have a moment to think about it. And it's like, what am I doing to make sure that I don't get HIV? And then if they don't come up with anything or say, well, I use condoms, I was like, okay, good, you're using condoms. Have you ever had sex without a condom? And then that then leads that conversation. So I don't necessarily, with my patients who are 18 to 24, we're just having a conversation about their sexual, like what you're doing. So I don't necessarily do anything significantly different than I do with my adults. But I think, maybe Matt can talk about his experience, since he mentioned in the beginning that he started PrEP when he was 18. So kind of how did your provider didn't have that conversation, but how was that conversation about sex and PrEP?
Yeah, well, my original provider didn't. Like I said, she didn't know what PrEP was, but my later providers, once I moved to New York, definitely did have those conversations with me. One thing I'd stress that's really, really important when you're talking to younger patients about sex who are thinking about getting on PrEP, especially if they're queer, is you want to put an emphasis on being non-judgmental about the questions that you ask, and even just your tone when you ask those questions, because talking, in my experience, being asked questions about my sexual practices when I've only had sex a few times and I never had any sexual education that could apply to me as a queer person. And I just becoming a sexual person as a whole was something I kind of, and most queer people do on their own, learning things through the internet, learning things through porn. So this is all to say, we have at age, 18, 19, 20, pretty not super developed sense of our own sexual lives. And so, in my experience, like having a doctor jump out the gate and ask me if I'm a top or a bottom was like a little bit of like a whoa, like, okay, like, it's I would say approach those things gently. And I know, because you're all adults, obviously it can be hard to relate to a very young person who's just starting their sexual journey, but tread lightly to get the answers that you need, I would say.
All right, thank you for that.
At the same time, I'll share my youngest patient that I had on PrEP was 15, and he was referred to me. His mom used to work in the ER with me, so that was great. Yeah, I didn't meet him and say, "Hi, are you a top or a bottom?" But I also didn't say, "Hello, I am Dr. Beringer. Do you practice anal insertive or anal receptive sex?" Because he didn't know what that, it's like, lady, what's up with the big words? Talk to me like a person. So we got to know each other a little bit. And then Matt, to your point, right? It's like, I'm not assaulting a 15-year-old with a bunch of really invasive questions. Take time to develop that rapport. If you're new to prescribing PrEP or to working in sexual health at all, just make your appointments a little bit longer, because I know we're under a lot of stress to see more patients and quickly and move them along. But you're talking to people about stuff that's really intimate. And so when you do, especially with young people, when you get that comfortability, then use like normal person language. Don't go into like medical provider robot mode.
Thank you. So I want to address one last topic in the last 3 minutes. I want to pull in Patris to assist me with this as well. So there was a question about, is PrEP now approved for use commonly in females at risk for HIV and HIV prevention? So a couple of things. The first drug that was available for PrEP, TDF, was approved for use in both men and women. The newer form that came out, TAF, was only approved for use in men and transgendered women. And the injectable PrEP is for use in all. So at this point, of the options that we have, PrEP is available for everyone. So it's not a matter of commonly being used. Females, as in the question, and women in general, were always considered within the group of people eligible for PrEP. And I want to pull in Patris to talk about your experience and how you came into this space as well.
So I came into PrEP because I went to the hospital, got checked, had 2 STIs, came back positive. And once I went back, someone from the clinic had came and talked to me about PrEP, and it was just easy for me to get on because it was like, preventative for me, because I was already exposed to 2 STIs. So they told me it was a higher chance that I could contract HIV. I didn't want that. So
I'm a semi-interview you now just because I have you on here. So did you have any hesitancy when they came to you and talked about it? Were you had any reservations about it?
No, I actually didn't know anything about it until he was very open, and very friendly. They had a whole pamphlet on what PrEP was. So he read it through with me, and, he was very open about it. And any questions that I asked, and then, he had answered them in the best way that he knew possible.
All right. Last question, our last 30 seconds for you, Patrick. You're going to close us out. Have you had conversations with your friends and family about PrEP in general? And
Yes, my friend, he is taking PrEP. If he didn't get on there not too long ago after I got on there, so we both actually take it.
Okay.
And it was easy for him to get on.
All right. Thank you so much. Thank you, everyone. Thank you to Augustina, Melinda, Blossom, Deja, Matt, Patras, Rachel, everyone, and all the participants. Thank you again. Hopefully we all walked away with something. All right, I'm gonna turn it back over to Rachel to close us out.
Thank you so much, everyone. Really appreciate your time and your thoughtful questions. Unfortunately, we didn't get to all of them, but we hope to have future webcasts and we'll see all of you back here. As a reminder, Faith put the link to claim your CME and CE credit in the chat. My colleague Samuel also let you know how you can get in touch with us via social media, and you could always access all of our free on-demand programs, and we also have other live programs happening as well at dkbmed.com. Thank you again so much, and it's just been a pleasure getting to know all of our panelists, and we hope to see you again very soon. Thank you so much, Dr. Robinson, Dr. Beringer, Melinda, Matt, Patras, Blossom, and Deja.
Thank you.
Thank you.
Thank you.
Yeah, I just want to make